You have been given a case of 37-year-old woman presented with intermittent headaches for the past 3 months. Her blood pressure is elevated. Regarding differential diagnosis, make a quick list of possible causes of a given presenting complaint, and ask questions to rule in, or rule out, the possible differentials, as in this case: essential hypertension, renal pathology, glomerulonephritis, ADPKD, reno-vascular disease, endocrine pathology, Conn's disease, Cushing's disease, acromegaly, or Phaeochromocytoma, aortic coarctation, preeclampsia, are the top differentials in our list. Here, we are discussing relevant questions to take a brief history, keeping ourselves structured within a given time frame. Now, we ask detailed questions using the mnemonics ONPRA. Onset. How did it start? Did it come on suddenly, or gradually? Duration. For how long is it present? Progression. Since the start of symptoms, is it getting better, or worse, or staying the same? Is it the first time, or were there previous episodes? Aggravating factor. Have you noticed? What makes it worse? Relieving factor. Have you noticed? What makes it better? Associated symptoms. Duration of symptoms, nature of headache, past history of hypertension, previous blood pressure readings, for example employment medical, with prescription of oral contraceptive pill, during pregnancy, other medical history, for example renal disease, cardiovascular risk factors, smoking, diabetes, known ischemic heart disease, drug history, prescribed and illicit drugs, alcohol consumption, visual disturbance, in accelerated phase hypertension, paroxysmal symptoms, Phaeochromocytoma. Check if the patient is pregnant. At this point, we have ruled out possible differentials and make our approach aligned towards a definitive diagnosis. To support it, we can perform a quick physical examination and lab investigations. As in this case, we can check body habitus, obese, Cushingoid, acromegalic features, radial pulse, radial and radiofemoral delay, for coarctation of aorta. Check the blood pressure yourself, with a manual sphygmomanometer, in both arms. Evidence of cardiac failure, underlying renal cause, polycystic kidney disease, current renal replacement therapy, dialysis transplant, ask to dip the urine, fundoscopy, for hypertensive retinopathy. Now it's the time to tell the patient about the management part, including investigations and treatment. Regarding investigations, we have options to check: evidence of end organ damage, fundoscopy, left ventricular hypertrophy on ECG, renal impairment, cardiac failure on chest X-ray, echocardiography, exclude underlying cause, by urine pregnancy test, urinalysis, and urine albumin to creatinine ratio, urea and electrolytes. Consider secondary screen, renal-aldosterone levels, plasma urinary metanephrines. Regarding treatment, we have plan of lifestyle modification, lose weight, increase exercise, stop smoking. Initial treatment: angiotensin convertase enzyme inhibitors or angiotensin receptor blockers. Age more than 55 years or Afro-Caribbean ethnicity. Consider calcium channel blockers or thiazide-like diuretics. Titrate dose to maximum tolerated. Consider other cardiovascular risk modification, aspirin, statin. Meanwhile, address the concerns of the patient. In the end, it's the time to close the case and talk to the examiner.